AlNasieh. As you see my profile here, I'm now working at King Saud Medical City and King Saud Family Medicine Academy as a trainer and a clinician also. I have a very vast experience, national and international. And I'm really very grateful to the organizers of this activity to give me the opportunity to be with you this evening and to share some of my little experience with your vast experience combined together. And I think we should come out with a conclusion which is useful to everybody regarding such a very important topic. So this is my objective of the presentation. So my objective of this evening, I wish to achieve, is there are very few objectives, and I think I'm going to achieve them within 40 minutes, hopefully, depending on the speed and the velocity we go with our interactive session. So I want to revisit actually an important old topic, because prevention is one of the oldest topics, as we know all. So epidemiology is old, and epidemiology is linked. If you go to any book of epidemiology, you find anything has to do with health promotion, anything has, because the study of disease, we are going to talk about diseases today. So the second thing is to provide actually the evidence-based information regarding different preventive tools. I was thinking of how I could present this presentation, and I just came to a conclusion that I think I should have some evidence-based information to some of our attendees this evening. Lastly, but not the least, is to remind some of us, one of my objectives is to remind some of us what we should know, what we know, what we should know, and more importantly, what we should do to our population at large and their health maintenance at all times. So this is by large my objectives and aims of this evening discussion. Hopefully I will achieve them. And any extra or extrapolating beyond this, I think should be useful in relation to the topic. So now I just want somebody, I don't know how we share, just to define to me, what do you understand by the term chronic diseases? Chronic diseases. Or chronic disease. What is a chronic disease?
Everyone, you can unmute yourselves and answer Dr. Abdulrahman.
Chronic disease, doctor, that means treatable disease, not curable. So lifelong diseases.
Okay, lifelong. It could be curative somewhat. Yeah, I agree with you, but definitely is a lifelong. So one of the main features is a lifelong disease, and that is why they call chronic. Okay, I agree with you. Any other feature in common to these diseases? Anything common among them? Yeah, I remember two diseases. Just contrast them and tell me what really brings them together in one group or in one bag. Dr. Saif? Anybody? Okay.
Recurrent.
Okay. 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 Or the symptoms can be recurrent. Some of them, they have a very long asymptomatic period. I agree with you, definitely. Any other additional information in relation? We are defining for people who has just joined us in, just we are trying to go to lay the ground for the discussion. What is chronic disease? So I just want somebody to wrap it up in 1 or 3 lines. Okay. So can somebody give me an example of the chronic diseases he knows or we are following?
Diabetes mellitus.
Okay, it definitely on the top of the list. Thanks. What else?
Hypertension.
Yes, that's true. What else?
Hypothyroidism.
All right.
Hyperthyroidism.
Okay.
Asthma.
Okay, bronchial asthma, definitely. That's good. Any other things around? Come on, there are many, I agree. Okay. Has complications if not controlled. I like has complication not controlled. This is a good thing. sickle cell disease and thalassemia, definitely. So we have two ways of saying it. Either we categorize it together. We say, for example, metabolic disease, endocrine diseases, cardiovascular diseases. I think it should be on the top of the list, because now we are going to see when we talk about the mortality and morbidity. Okay, let me see my first definition I put for you here, but this is a very good contribution and a good start. Thanks a lot. Okay, now, so طبعا there are many definitions. Provided you gave the main meaning, it is okay. In any way you frame it, you must understand the core meaning of the whole issue. So chronic diseases are heterogeneous group of disorders, but many share underlying causes and risk factors. And this is a very important issue, because we are going to talk this evening about causes and risk factors, because cause, risk, epidemiology, and so on. Now, these diseases require ongoing medical care. Regarding the duration, they call them chronic, but you know all that, for example, when did the diabetes start? We all know. So when did the diabetes start? When will you call a diabetic patient he has a chronic diabetes? Anybody? Or hypertension? But we know hepatitis, 6 months, for example. And we know some diseases 1 year, then before you say it is a chronic infection. So what is it there? And for diabetes and hypertension, for example, or dyslipidemia. So here where the issue, that's why I put duration question mark. You see, for diabetes, you all know that for type 2 diabetes, especially, that these patients have the ailment and the damage, unfortunately, even before they present. And this is very important. And you know, we know it, yani very, very important topic coming up now. Okay, what we call the legacy effect. I'm sure you read about it. And I mentioned it in many of our discussions regarding these chronic diseases. So the legacy effect, that the disease will start even before it presents. So the memory, we call it metabolic memory or the legacy. So usually these diseases, or some of them, may limit the activity of daily living of the patient who is afflicted with it. Now the new name coming up as our meeting in the Ministry of Health here in Riyadh, we call them non-communicable diseases. طبعا here this word, well, some people may argue it has some genetic communicable way of saying it. But what we mean by non-communicable diseases, for example, is not like brucella or malaria, for example, or hepatitis. So that is the meaning. So the group has another name in addition to chronic diseases, is non-communicable diseases. So many are linked to lifestyle factors. And we may have to blame us, our communities, for changing their behavior, being sedentary, eating unhealthy foods, and so on. So personally, I believe the society is responsible, and it is a system problem where we have this problem. And you see this in the next slide, that it is the society who really determine our behavior since we are very young. How? Promotion of tobacco, which is still going on in many countries in the globe. Salt hidden in processed foods, Saudi Arabia. High sugar in many drinks is still going on, although there are some restriction, increased tax in Saudi Arabia. High saturated and trans fats, still a lot. Then the being urbanization, or getting urban, transferring people from rural areas to urban life. So this is some of the factors actually of this issue of regarding chronic diseases. So I just wanted to sensitize you that the issue is not only the behavior, the responsibility is not only the patient, but it is the community and the community leaders and the healthcare leaders and the healthcare providers, not least. So please remember, so it's a multi-agent form of responsibility. I hope this is clear, just to lay the ground for this discussion. Now, having said that, this is a societal factors. Shall we talk about the mortality and morbidity? We all know, without any dispute, that cardiovascular disease are the top diseases which are causing the highest morbidity and mortality all over the globe. So you talk of hypertension, what is the commonest cause of death in hypertension? Cardiovascular. What is the commonest cause in diabetes, which is a cardiovascular equivalent, I believe, is cardiovascular again. So even the malignancies, They are talking now, the main cause is cardiovascular cause. So you look at many of the chronic diseases, at the end, because of the mortality and morbidity, it has to do in one way or the other to the cardiovascular link. So that's why I put the cardiovascular, unfortunately, like most of the diseases, they don't have symptoms or obvious signs of any vascular diseases. Somebody can just come to the ER with CVA, which is unfortunate, or with myocardial infarction, and he will have no single symptom 1 hour before. So they have an ongoing atherosclerosis, which you know, which is going over the time, starting even from the womb. When the child inside his mother's womb, so that's why some of the new studies are following these kids from infancy. So an increased risk of vascular events, we know, there are many, and I don't believe in this, a lot of numbers, but 40% of the mortality globally is contributed to these problems. So that's why I'm giving it a priority. That's why I'm bringing the evidence for these diseases. That's why my concentration this evening is on this topic. Now, the second group we all know are the malignancies. And I'm going to also mention 3, 4, 5 slides about them. Chronic respiratory diseases are known. This list can never be inclusive. There are so many topics we have not mentioned. And I will show you my second slide that things we always ignore, even our planning and so on, that we forget about these diseases, and they're very important and they contribute a lot to the mortality and morbidity, e.g., injuries and accidents, multiple sclerosis, dementia, mental illnesses, osteoarthritis, chronic kidney diseases, glaucoma, occupational diseases, pediatric gains, including falls, incontinence, and so on, dental problems, thyroid, just somebody mentioned it. I didn't even put it here. You see, we always miss many of these diseases. So what I can call that it is something always with us in the clinic. Daily we see 4, 5, 6, 7 diseases rather than diabetes and hypertension. So this is why I put this slide that chronic diseases, many are considered for maybe logistic reasons, financial reasons, economic reasons, organizational reasons, we don't know. But we always don't remember most of them, these diseases. Okay, now let us take, I'll just go back. Yes, I want somebody to tell me what does he understand by the term health promotion. Health promotion, anybody? Anybody can define to me the term health promotion? Anybody writing anything? Nobody yet.
If you allow me, Dr.
Okay, can you just raise your voice, please?
Part of primary prevention, doctor.
Okay. Yeah, primary prevention is very excellent. This is part of the health promotion. But what is health promotion? Bring it to me totally together in one word. Or one sentence, I mean. Yeah, okay, primary prevention is part of health promotion. But is it the only activity we do and we call it health promotion? So if I vaccinate my kids in the environment and give them flu and COVID vaccine in my primary health care, it means I have done health promotion to my population, or there are some other activities? And I'm sure you know there are many other activities. Go ahead, sir.
Health promotion includes many things, right from the nutritional modification, environmental modification, immunization.
Very good.
So simply in the COVID process, application of the mask and all these things comes under the health promotional measures.
Very good. That's why they said to maintain and improve health. That's very excellent. And what you said is definitely right. But you have to remember, doctor, if you have a patient who is coming for upper respiratory tract infection and you check his blood pressure, and it happens many times, and you got the BP very high. So there is another activity going in here, we know, is secondary prevention. You know it. Since primary prevention, I'm going to give so many examples of primary prevention because many people believe, and residents, that it is only vaccination and so on, but there are many activities. So this is very excellent. Again, to complete the whole thing is to think of tertiary prevention, which we have to say it, and it's very unfortunate if most of our activities are tertiary prevention, as we define it now. So I want somebody to tell me what is the difference, what is primary prevention, what is secondary prevention, and what is tertiary prevention. Just 3 people, if it is
primary
convenient.
prevention is action or intervention is taken prior to the onset of the disease.
Very good. Excellent. So you anticipate. We call it the state of anticipation. So I vaccinate my kids against rotavirus, against, for example, hepatitis B and so on, because I'm doing anticipation care. Excellent. Excellent. And it is usually a population-based approach. Excellent. So what is secondary prevention, which is a whole discussion today? Secondary prevention.
Early detection of disease.
Early detection of disease. Excellent. Excellent. Pre-symptomatic. Yes, go ahead, sir.
And the early detection of disease in a symptomatic stage.
Okay. So what is tertiary prevention?
Prevent complication or decrease the complication.
Prevent complication. Very unfortunate state. I hate saying it always to my resident because it presents our failure as family physicians and primary healthcare physicians. So if in a community I have a lot of complicated cases, a lot of, for example, amputated legs, blind patients, I think this is unfortunate. We will present our failure as a system, as a healthcare providers. So we don't pray to have such very, debilitating, advanced stages of diseases. Okay, now let us concentrate. The definition of primary is very clear and we are going to give the examples, but I want to talk more about secondary prevention because this is the main activities the 2030 mission and vision talking about, and we have been doing it for years now. So I want somebody to go more to give me the word which the epidemiologists use, which is just interchangeably used for secondary infection. What is that word? And it gives the same meaning. So you said pre-symptomatic detection or detection of diseases at early stage. So what is this activity called? One word. Now I was screening. Screening is already in the screen here for me. Excellent. Screening. So these screening programs are going in Saudi Arabia and other Gulf countries and the whole globe. Everybody is screening patients, hypertension, diabetes, pre-diabetes, everybody is going. So we know, because of the time we're not talking, but just to remind you, you know, that each disease has to satisfy a certain criteria to go for the screening. And we know what are the commonest 3 diseases we are screening in Saudi Arabia, or 4 diseases, let us say. So what are the diseases we are screening as primary care physicians, and we have guidelines for them? What are they?
Breast cancer.
Breast cancer, number 1. Yes. And this means now when we come to the criteria, you will get this. Yes, breast cancer. What else?
DM.
DM. Excellent. I just want 2 more examples. What else?
Colon cancer also.
Colon cancer, actually. And this is what is going in this country. Excellent programs. Okay. Yeah.
Asthma.
Asthma, okay. But asthma, we don't screen as such, but asthma, it can be. But I want a more active screening you are doing in your primary care. What of checking weight of patients?
Dyslipidemia.
The blood pressure. That's in the commonest screening program, in addition to breast and colon cancer and malignancies, is hypertension. Screening for asymptomatic silent killer. Very important, hypertension as a screening. So from what you said and what we said together, hypertension is there, dyslipidemia is there, depression is there. All this we screen for them, and there is always many tools to screen them with, and which are important, definitely. So these diseases you mentioned and others, and I can see on the screen, as I said, hypertension, these diseases are common, 1. So what are the features for a disease to be included for a screening program, so that we take the time of our healthcare providers, the money, and everything is directed towards, for example, screening of the breast cancer, for example, because it is common, it is really has a stage, the most important point, and we must get a stage where we can intervene to reduce the mortality or morbidity. Otherwise, we shouldn't do the screening. If it is not at a stage where I can do something, in other ways, I must have what I can do for the patient when I discover he has the problem early. For example, hypertension. So do I have the health educator who can educate him about his lifestyle, for example? Do I have the drugs available? Do I have the planning for follow-up of this patient, and so on? So you must not only discover the disease, but you must have early plan which tells us that when this patient is discovered to have, for example, diabetes, this is what is going to happen to him. So this is very important. Yes, I know there is Wilson criteria. I'm just reminding you, and there is modified Wilson criteria, and the features goes up to 15 features. So screening has this. This is number one. And what are the other features you look for when you are screening a patient regarding the test? Let us say the test. For example, for breast test, and there are changes, as you know, updated ones. For example, self-examination is no more evidence-based, and they don't advise for it. Example. So what are the features you need in a test? So what are the criteria? What are the parameters of a diagnostic test when you are doing it? Even if it is a blood pressure measurement, if it is a malignancy screening, looking for markers, malignancy markers, we all know them. So what do you think other features we should have before we start screening?
Sensitivity and specificity of the test.
Very good, very good, very good, excellent. So the test, you should know the sensitivity in comparison to the specificity. What else? What is the most important thing in relation to a diagnostic test? If you talk about diagnostic test, so what is the most important thing?
The test.
Criteria for the screening.
Yeah, the criteria for the screening, I mentioned Wilson and the modified Wilson, which I know all of you, you know it. But the test, regarding the test, and this is where evidence-based comes in, you see? So a test should be, has certain criteria, positive predictive value. What is the positive predictive value? It means, what is the possibility it will detect to me a patient, the mammogram will detect to me a patient who is having an early breast changes, for example. And what is the negative predictive value? If the patient doesn't have the disease, what is the percentage that this disease really will not be seen? So I will not get any false positive there, and contrary in the other one. Then the pre-test odds. What are the pre-test odds of this test? What is the post-test odds? What is the pre-test probability, which is the prevalence? And what is the post-test probability? So there are many features also to the test. And this is evidence-based, very important. Okay, now I'm very happy that the coming slide, you already said them. I will just tell you the reframing of these definitions. Okay, so now we move to primary prevention. Primary prevention, okay. So generally prevention, by the way, it is action to stop something from happening. So we prevent disease or injury before it ever occurs, as you rightly said, some of you. Prevent exposure to hazards that cause diseases. Altering, this is very important, altering unhealthy or unsafe behaviors and increasing resistance to disease should exposure occurs, and this is vaccination. And it includes prophylaxis, as you will see very soon in the examples I have given. Now, secondary prevention, I have 2 slides summarizing everything. Regular health checks, we need to remember this, are invaluable because many diseases are detected during such process when they are in their early stages, and we talked about that. It is also known that some diseases are without symptoms, asymptomatic. That's why I said pre-symptomatic detection, until they reach an advanced stage, when, unfortunately, irreparable damage must have been done to the person. So to avoid this, family physicians need to read and adopt an updated recommendation regarding early detection of chronic diseases. And every day we are getting new guidelines, new guidelines, new guidelines. So secondary prevention, again, that detecting and treating diseases or injury as soon as possible, as much as I can. And this is time, the natural history of the disease. It has to do with many factors. So our objective should be to halt or slow the progress of this disease. Encourage personal strategies to prevent any damage or injury or re-injury to the person or recurrence. So what it means in secondary prevention, we need to implement programs to return people to their original health function, if we can. Yani, it's a difficult thing, but let us hope. And function to prevent long-term problems and complications and taking us to tertiary prevention. We don't want to reach that stage. So it's a balance actually between primary and secondary. I always don't talk much about tertiary because I don't want to reach the tertiary stage in our community, or the percentage with complication should be very low in the number. It is an early intervention that reduces the prevalence of a specific problem. So this is a very good statement talking about secondary prevention. It is an early intervention that reduces the prevalence of a specific problem. Okay, so now, before we give the tertiary prevention, I'm going also to look at primary, secondary, and tertiary together in some presentations very soon. You will see very soon. Okay, let us talk about simply tertiary prevention. Tertiary prevention is treatment designed to improve the quality of life and reduce the symptoms after a disease or a disorder has developed. So this does not reduce the incidence and prevalence. So, sorry, Yani, although some of you might be very fast readers, I want somebody to define to me what is an incidence of a disease and what is a prevalence of a disease. Anybody?
Incidence is occurrence of the new cases in a given population.
Incidence of disease are
period
new
of time.
cases. So what of prevalence, doctor?
A number of existing cases in the given population.
Yeah, existing. The word you brought, I'm very happy. That's why I bring my slide immediately. See this diagram I'm putting here, I got it from the net, very useful diagram. So the incidence, the number of new cases. The prevalence, the existing number. So proportion, epidemiologists like numbers, percentage. So it's proportion of people who have a disorder during a particular time period. This is the prevalence. And proportion of rate of persons who develop the disorder, the new cases. So please have a look at this diagram. It's a very useful diagram. Before I show you more diagrams to wrap up health promotion and the 3 types of prevention, including what we talk about now, the new papers about primordial prevention. Again, this is just a diagram representation of what is the whole thing we are discussing. Okay, avoiding development of diseases, early detection, reduce complications. So it's the same thing, one by and large. Again, the same diagram, but in another way, adding primordial form. They talk now of primordial, which is very difficult. But some good books I looked at and papers, they are dividing that vaccination and so on. This is more of primordial. And if you look at the kids from they are young, even when the child is in infancy, it should be something like that. But I personally, I don't feel any dichotomy or I cannot feel the blurred line between primary and primordial, whatever the epidemiologists say, unfortunately. So I still believe it's primary, secondary, and tertiary. But well, they are saying, when I checked out some papers, they said in PubMed, they said this is applied to hypertension, for example, and some of the metabolic diseases, dyslipidemia, and so on. So is maintaining health? Well, okay, avoiding the risk. Reduce and eliminate, almost the same, primary. Minimize severity by detecting early. And complications, tertiary. This is just by large. Yeah. I'm just trying to put it by large. But I just tried to bring 2 slides in summarizing 2 main conferences, the Third Heart International Conference and the Ottawa Defining the Health Promotion. So this is what this conference has said, that cardiovascular risk prevention had to be encouraged throughout the lifespan of a human being. And we should have availability of cheap, healthy food. We should promote desirable eating habits in our kids since they are young, even before the school age, I believe, to ensure they have favorable risk profile when they grow older. This statement is very important, ya Jama'ah. I will read it again. Promoting desirable eating habit and other exercise and so on in school age to ensure they have favorable risk profile when they grow. And this is the issue. I have a patient in my room this afternoon. His age is 54. He had a lot of risk factors coming inside into his heart. So you see, if we do that, at least, yes, he's a male, I can't change that. He's coming from so-so area, I can't change that. All right, but favorable risk profile for the modifiable risk factors. And I'm sure you know them, the modifiable and non-modifiable risk factors. So many metabolic things and so on. So we need to have a favorable risk profile when we grow older. That is what is the essence of the whole discussion. Okay. Now, what of the Ottawa Defining Health Promotion? Now bringing the administration in. And this is in Third International also, but the Ottawa Charter defined the health promotion action in the following ways. Build healthy public policy, create supportive environments, strengthen community action. This is very important, the participation. Develop personal skills, and reorient your health services. So many people ask me, what is this reorientation of health services? So can somebody tell me give me an example of reorientation of the health services? Anybody? Reorientation of the health services. Anybody? Is it prioritization? You prioritize things in your care, that I have diabetes more, so I need to have more machines for diabetes, not to have EMG machine in my clinic. I don't know. To have an ophthalmologist, but not a neurologist in my clinic. I don't know. So what is the reorientation of the health services?
سلام دكتور نصيح، كيف حالك؟
الله يطول عمرك. I hope you hear me.
I hear you very well. أصلاً اليوم ما حضرت إلا لأنك
how is the discussion going on?
والله أنت دائماً you are the top, you are the best. أصلاً ما حضرت غير لأنك أنت اللي حتقدم.
يديك العافية.
Reorient, الله يسعدك. Reorient health service. I think the meaning of instead of putting a huge amount on curative, instead of it we have to put on prevention. Instead of waiting the patient to come to us, we have to be proactive and start registries, start to go to the patient risk factor, go to social environment, and these things.
Excellent. And this is what we want in our primary healthcare physicians now. If you see a patient, please remember risk factors, risk screen for risk factors, so that you may discover many you can modify. Excellent, Doctor. Thank you very much, really. So somebody asked me also, what is this reorientation again? Can you give me a typical example? Anybody? Okay. I am always criticizing people who write too many and too much antibiotic in our primary healthcare centers. So I always tell them, I delivered one lecture. I remember I am always involved in diabetes conferences in the National Guard a few years ago. And I asked the attendee that whether we could have a glucometer to every diabetic patient in Saudi Arabia. طبعا the majority, they are right. They said, Dr. Abdulrahman, this is not possible, only people on insulin. But when we finished that discussion, all of them got convinced everybody in Saudi Arabia could have a diabetic who could have a glucometer, even a pre-diabetic. So they were surprised the way I said it. And I told them, okay, I brought from my center that time, Khashmalan, many years back, that some latest 100 prescription for antibiotic for people coming with upper respiratory viral infections. And we calculated, very interesting session. Yalla, antibiotics, this, that, calculate the money. We discovered that augmentin is 87 riyal. Zinat is 75 riyal. And we calculated the money, and with these people, they are receiving a lot of unnecessary antibiotics. So I think there should be a reorientation of the way we deliver our care. So that is what I mean by large, and I'm sure you get my point. Is it clear, this point, ya Jama'a?
Yes, absolutely.
Okay. Now, because of the importance of this, I will give you many examples, as I told you before. We believe only vaccination and so on about this primary prevention. Then I will define more and explain more primary prevention, especially in relation to death, because people believe death is the cause of the whole cardiovascular, diabetes, hypertension, and so on. So I will give that. Let us see so many examples. I will rush through them about primary prevention, tools available. Okay. Active vaccination, healthy foods, regular exercise, avoiding sedentary life, all these are primary interventions. Food fortification by iodine, folic acid, water, chlorination, adolescents and school health programs, violence prevention, substance abuse prevention, use of condoms, husband, wife, hepatitis B, and so on, no smoking areas, do not share personal items, seat belts and helmets use, public health, the sewage disposal, hygiene, hand washing and hand rub, and we are very aware, or we are in the era of that, mosquito nets, prophylaxis, pregnancy prevention in people who are sickless, people on teratogenic, some females, how we can prevent pregnancy so that we do not have a lot of mortality and morbidity. So in other words, primary prevention again, and because it's important, and death, in relation to death, death is an important cause of many chronic diseases, as we know. So changing behavior has the potential to decrease the burden of many of our chronic diseases. So improving cardiovascular outcomes in healthy people without existing cardiovascular disease or elevated risk factors, this is primary prevention. Again, small changes in lifestyle have profound effect on the risk of CVD or cardiovascular diseases over decades. So this is very important statement. Again, to revisit secondary prevention, systematic application of a test or inquiry to identify those who are at a sufficient risk of a specific disorder to benefit from further investigations. Or we direct our preventive action among those who have not sought medical attention. We look for them at home. We go and look for them at home on account of symptom of problem that which is asymptomatic. So we know screening, and you know it in many ways. So we should be able to define, and we talked about all the parameters, I mentioned them. Now, having said that, we need to see if we want to achieve our objective, what do we need? So how will we achieve our aim? To me, I believe, although we all hope to prevent any disease from occurring at all, but I think this is a remote aspiration for many reasons. We don't have the biological, clinical, or epidemiological data which is needed for implementing an effective or effective preventive program. In other words, we need an evidence-based information about any primary prevention we do, any secondary activities we do, and even any tertiary activity we do. But as I always tell people, evidence is not always there, and evidence may be there and it may not be rigorous. So that is what we think. But I want somebody to give a statement. How can we achieve our aim? And our aim, I will repeat again, is to eliminate ailments and diseases from our society. Have them coming just for what we call well-man clinic, well-baby clinic, well-woman clinic. How will we achieve this? Anybody can contribute? How do we hope to prevent diseases? How do we put it together? Do health promotion. Anybody? So somebody is inside, for example, premarital screening test, excellent. This is very important. So we use reliable tests, I agree with you. So how will we go through our objectives? Anybody? Okay, now because of the time, I looked at the watch now. Now, what I'm going to present in the next 10 to 12 slides is I went through what we call the British Medical Journal Clinical Evidence References. And this is some of our few journals of evidence-based which I received. Unfortunately for me, I got surprising results regarding cardiovascular diseases. What is the evidence-based primary prevention we are using, and what is the secondary based evidence-based procedures. And this is what I'm going through it. There are so many, we don't need to cram anything. It should be in the clinic. So this is what I'm going to do. This is the main bulk of my presentation, having laid the ground for that. Again, I'm repeating, I'm going to present to you an information from the clinical evidence. Not only that, it is a BMJ series where we receive this. And this is the cardiovascular prevention program, clinical evidence. Okay. So these people mentioned primary prevention, for example, of cardiovascular disease. Use of the diet. They said likely to be beneficial. And this is how the evidence is presented. Likely to be beneficial to reduce the cardiovascular diseases. Advised to reduce sodium intake because it has an effect on the blood pressure. But there is no evidence-based data in reduction of mortality. Unknown effectiveness is to give advice for these in isolation. For example, increasing fiber intake to your patients, only this advice, not in combination with the remaining two, for example. Increasing fruits and vegetables alone, or reducing fat intake alone. So if you don't combine them together, they will be of unknown effectiveness, according to the recent evidence. What of cholesterol lowering interventions are low risk people of coronary heart diseases? Likely to be beneficial if they have cholesterol intervention lowering as a primary prevention, by the way. Statins in those at low risk, likely to be beneficial. but of an unknown effectiveness in low risk is using ezetimibe, fibrates, niacin, and resins. This has no known effectiveness at all. Again, what of the medium risk? Beneficial fibrates. I was really surprised when I got this material. Likely to be beneficial statins in this group. Unknown effectiveness, again, ezetimibe, niacin, and resins. And we are going to rotate around these 5 things. Now, what of the high risk? High risk primary prevention, cholesterol lowering intervention in people at high risk of coronary heart disease, beneficial statins. Unknown effectiveness, now the fibrates came up here with these 4 groups. Likely to be beneficial is to reduce or modify the fat diet in a patient, especially in low, medium, and even high risk. So this is for all of them is likely to be beneficial if you modify the diet. What of the primary prevention when you treat hypertension? Likely to be beneficial is to use fish oil and low salt diet. Unknown effectiveness, to tell them calcium and magnesium supplementation. What of unknown effectiveness is still? Antihypertensive drugs in relation to what? No antihypertensive drug has been found to be more effective than the others at reducing all-cause mortality, unfortunately, or cardiovascular disease mortality or myocardial infarction. Diuretics may be more effective than AC inhibitors and calcium channel blockers at reducing heart failure. Angiotensin converting enzyme inhibitors may be more effective than calcium channel blockers for prevention of coronary heart diseases. So this is the primary prevention for cardiovascular disease. Still, what of the physical activity? Likely to be beneficial is to increase the physical activity. Will lead to the increased physical activity in healthy people without existing cardiovascular disease. So counseling people to increase physical activity or to perform higher versus lower intensity exercise program is likely to be beneficial. Unknown effectiveness in relation to cardiovascular outcomes in healthy people without existing CVD. So they are saying there is no effectiveness if you do that. And this is the statement, I'm just copying it. Now, what of secondary prevention of ischemic cardiac events? I'm going to discuss the cardiac and CVA mainly. So long-term treatment to prevent recurrent cardiac morbidity and mortality, that's what I mean by secondary prevention in relation to ischemic cardiac diseases in people who have had either a prior MI or acute coronary syndrome, or who are at a high risk due to severe coronary artery stenosis or prior coronary surgery. So what is the secondary prevention? Beneficial aspirin, Blavex, which is clopidogrel, and aspirin. Likely to be beneficial, well, they are talking of clopidogrel, ticopridine, and prasugrel. Likely to be ineffective or even harmful is to give any of these glycoprotein 2B, 3A receptor inhibitors, apixaban, antirubifan, and so on. What is still secondary prevention of ischemic cardiac events? Other drugs may be beneficial, AC inhibitors, amiodarone, angiotensin receptor blockers, and beta blockers. I told you this is a big list. I'm just going through it. Secondary prevention of ischemic cardiac events, unknown effectiveness, combination of AC inhibitors and angiotensin receptor blockers, and this is not allowed by all means. Likely to be ineffective or harmful to give calcium channel blocker for secondary prevention of ischemic events, quinidine, proquinamide, or hormone replacement therapy. What of the effects of cholesterol reduction for secondary prevention of ischemic cardiac events? Beneficial, non-specific cholesterol reduction, whatever you do, or you give statin. Likely to be beneficial is to use fibrate. So what are the effects of blood pressure reduction for secondary prevention of ischemic events? Beneficial, definitely blood pressure reduction. So what are the effects of non-drug treatment for secondary prevention? Again, beneficial, you do cardiac rehabilitation, it includes exercise, smoking, and so on. Likely to be beneficial, advised to eat Mediterranean food, for example. Increase fish oil, either in capsules like we use now, or psychological stress management and reduction, smoking cessation, and so on. This is likely to be beneficial as secondary prevention of ischemic events. What are the effects of non-drug treatment for secondary prevention of ischemic cardiac events? Unknown effectiveness is to advise to eat less fat or advise to eat more fiber, but unlikely to be beneficial antioxidant, and we are using it, unfortunately. Vitamin combinations, multivitamins, vitamin C as an antioxidant, Likely to be ineffective or harmless, beta-carotene and vitamin E. And I can tell you from my experience, many patients come to ask for vitamin E as an antioxidant. So it's not useful in these categories. This is evidence, ya Jama'ah. طيب, what of stroke? How will we do secondary prevention for a stroke in people who have previous stroke? Beneficial aspirin combined with dipyridamole, antiplatelet treatment, Plavix, blood pressure reduction, cholesterol reduction. We do that, fortunately. Unlikely to be beneficial, high dose versus low dose aspirin. There is no benefit, 305.1 or 81 or 100 milligram. So no additional benefit and may increase harm. So low dose is advised. Vitamin B supplements. Likely to be ineffective or harmful to use anticoagulation in any form. What of the effects of preventive anticoagulant in those even without previous stroke? Beneficial oral anticoagulant. Unlikely to be beneficial antiplatelet and aspirin. The same list comes here. What are the effects of preventive anticoagulant and antiplatelet in people with atrial fibrillation and previous stroke or transient ischemic attack? Beneficial oral anticoagulant and non-effectiveness as aspirin. Now, having overloaded you with this new evidence, I want to criticize the evidence, clinical evidence, as an evidence-based teacher for years. Clinical evidence, it has some limitation. Please always remember, the evidence is not enough alone. You need your experience, experiential learning, and you need the patient values and expectation. That is why most of these papers, if you go through them, even the GNC8 evidence, a lot of confounding factors were difficult. Even they acknowledge it's difficult by the researchers to adjust for. Slow build of atherosclerosis, very difficult studies done on cardiovascular diseases. Risk factors, they will always look for risk factors and not disease outcome. And what we mean by disease outcome is mortality and morbidity. Again, diet control will lower the risk of cardiovascular disease by exerting favorable changes, like on body mass index, on diabetes, on blood pressure, or lipids. We know that. This is really happening. Again, diet. But before I move to my last 3-4 slides and conclude, I cannot pass prevention, again, primary of cancers, of increasing body weight, and of accident. And this is what I'm going to discuss about lifestyle, healthy lifestyle counseling. Again, reminding all of us at the conclusion, heart diseases, malignancies, chronic respiratory diseases, stroke, accident, metabolic diseases. This is the most common causes of this. Again, cardiovascular is #1. So we aim at preventing these most causes of this. Healthy lifestyle, primary prevention of cancers, very long list. I'm just summarizing it. Avoiding ultraviolet radiation, appropriate sunscreen use, avoiding alcohol and smoking, choose food wisely, achieving and maintaining body weight. And the last, #5, it is implicated in most of the malignancies, unfortunately. So this is, there are many, depending on the cancer. For example, each cancer, breast, colon, has its own risk factors, but this is by and large. So what of the accidents? Routine use of seatbelt, we know, and helmet for motorcycle, smoke detectors, weapon safety, heaters at home, general public education, and the parents for kids, improving bicycle lanes and people who do exercises, home safety measures, and so on. This is just to sensitize you. Remember, accidents are common cause of morbidity and mortality. Lastly, but not the least, is the increased weight. Eliminate, how would you do primary prevention for obesity? Eliminating sugar-containing beverages, implementing reduced calorie diet, avoiding processed food, practicing mindful eating, we know that, physical exercise, avoiding sedentary life. So this is by and large. I know you know most of these things, but we bring it together, we remind each of us because they are important. Again, the whole story about lifestyle is as a primary prevention. Sleep hygiene, stress reduction, taxation and pricing, food stamp programs, making healthy choices as the default option, promote purchase of fruits and vegetables, and inhibit the purchase of unhealthy foods. Before I conclude, I just want quickly to rush through involving our patient, decision-making. So what is a shared decision-making program? Because all what I have said, if our patient do not agree to it, is a failed program. And I always bring the patient at the center of any activity we do. So patient decision aid or support tools they are talking about now are the most modern things, are means of helping people to make informed choices about healthcare, treatment, screening that take into account their personal values and preferences. And this is the parcel and heart of evidence-based medicine. They bring high quality information and informed discussion about treatment options and screening tools. A Cochrane review provide, and I'm going to give you the evidence from Cochrane very soon about the evidence and benefit of these tools. So take home messages. No decision aid, this is my own statement, please. No decision aid can replace the power of consultation skills, counseling skills, and conversation with our patients. Please, this is my message to you. Patients should have their autonomy when they discuss with their clinicians such an important decisions regarding vaccination to themselves, to their relatives, to their kids, screening, and so on, and rehabilitation. The issue of COVID-19 is known to everybody, the vaccine, I mean. So decision aid model is a shared medical decision-making process where patient, their relative, their provider discuss the most risk versus benefit of any activity we do or any different care action we provide. Patients should be given the opportunity to reveal their preferences, their health beliefs, their feelings, their worries, their expectation jointly to make any decision. This is a growing expectation and a strong decision-making tool that is gaining momentum in the modern clinical practice era. So this is by and large. So what is the last statement I want to see? One or two statements. Recent evidence has shown that these decision-making tools has facilitated significant increases in knowledge. This is Cochrane. The computer-based information tool, the decision analysis tools, individualized and group counseling interventions has significant effect in reducing anxiety level. Again, evidence-based. The computer-based information tool and the decision analysis tools were associated with reduction in the level of decisional conflict. When you inform your patients well, when you give them chance to balance the risk versus benefit, there will be no conflict in the discussion. These tools can assist healthcare professionals to provide up-to-date information and counseling about the different choices regarding the screening for these chronic diseases. But what of what we are doing today in Saudi Arabia? To achieve these goals of health promotion, we must know about certain diseases common in our society. This is number one, their risk factors and symptoms. I told you is a multi-agent. The importance of all stakeholders' efforts cannot be overemphasized. So it's not only the physicians, it's not the nurses, it's not the leaders, it is everybody coming together. It is necessary to remember that most healthcare professionals are more interested in treatment than in prevention, unfortunately. This is maybe due to the fact that the demand for clinical care is high. Also, they receive financial benefit for treatment from our consumers, all the private clinic, including most of what is going on in the Ministry of Health. So there is no such benefit for preventive care. So what I mean by here is there must be incentive, like in UK, for screening, prevention, and so on. All kinds of things, providing, for example, osteoporosis screening to our elderly. So there must be some incentives for the prevention also. Now, this is a thought for all of you, just to think about it, and I've finished. What has happened, this is my own conclusion. What has happened to our chronic diseases patients during the COVID-19 pandemic? I know the time. Was virtual clinic provided the required health care to our patients? All the medical and personal behaviors and health was focused on COVID-19 and not on any other ailment for the last 2 years. Was that ethical? And now I leave the floor for you to comment. Thank you very much. This is all what I have.
Thank you so much. Impressive, Doctor. Thank you so much. And very difficult questions to be answered. Let's hear from
all of you to answer. Yalla, for all of you to answer, our seniors and juniors, to answer my 3 questions I framed this morning. I know it's time for prayer, but some of us has to wait for a few minutes to answer these questions or try to answer it. It's difficult, I know.
Wallah, it's very difficult to answer, especially that the
good.
chronic
It's for you
diseases.
for reflection. Actually,
Yeah.
I don't want the answer. I'm looking for you to reflect, to think about what is going on in the last 2 years regarding our chronic disease patients. I really pity them actually.
والله أنا نظريتي يا دكتور نصيح إنه اللي ما حيموت في كوفيد إحنا بإذن الله حنموته neglecting his chronic disease.
That is the conclusion of these 3 lines. Thank you very much. We hope that will not happen inshallah يا دكتور.
لا حول ولا قوة إلا
لا ما
بالله.
صراحة أنا والله لأنه these statements reflect I bear responsibility to these 3 questions because I reflected, you know, I have a very long experience and I've been worried about these patients when everybody, the clinics closed and so on, everybody is running away from healthcare centers and so on. So I said, look, what is these people? What is their hemoglobin A1C during these days? What is their visual acuity now going on? What is their weight? What is happening? So all things we forgot it and now we are worried about wearing masks, doing this, washing our hands. So it's a reflection for you. It's just to make the session live, that's all. And that's what I do always with my residents. I always give you something to reflect on. So it's not cramming, it's not pouring information. You can get it anywhere, but it is this discussion I like. So I wish this session was useful to all of you or added something to you. And I thank
والله
you.
رائع. Thank you so much, Doctor. If there is any questions or comments before we close the floor, I know it's break time.
If I don't know the question, I will tell you I don't know it. So you didn't see me, so you will not meet me on the road and ask me.
Doctor, we'll catch you anywhere now. It's very easy by the technology. Anyway, if there is any comments from the audience, floor is open.
Okay.
Thank you,
Or
Dr.
feedbacks.
I'm Dr. Tazim.
Anybody, please, I want to raise your voice. We listen to you. I will be happy.
Are you hearing me, Dr. Abdulrahman?
والله دكتور, prevention better than cure. الوقاية خير من العلاج, and definitely if we work hard in preventing the disease to happen, things will be better. And as you said, now the chronic diseases is more, and after post-COVID, we are seeing all the consequences of having the patient long time away from the practice, and the patient who got COVID and they have a long COVID consequences. And this is يعني صراحة العالم الآن عنده ضريبة والمضاعفات الكوفيد is everywhere, either from COVID or the consequences of ignoring the patient in the COVID time.
Very good. Very good.
And we are facing this in reality. We need to go up and catch our patients and try to either try to help them and try to catch them where they are. And this is so difficult, but we need to think about it. Let's see if there is any other.
Please remember, Anu, I prepared actually 20 questions and I sent 8 questions and one of them was chosen. I'm very happy. This is a question I wanted to be chosen. So I'm getting the answers. So we know the answer very soon. I will read it.
Dr. Abdulrahman, I have put up all 8 questions.
Okay. Upload and let us see the answers. I'm ready. I'm waiting. No problem.
Okay, we're going to launch them one by one. So I'm just giving everybody some time. So only 6 people have answered so far.
Okay, excellent. Excellent.
Poll closed now. If you can share with
this
them
question, I think the time is enough for it now. So now stop sharing and let us see. So this man who doesn't have the time and so on, we know the answer is correct. Can I answer? Yes, perceived barriers to action. Actually, this is the answer. Let us see the next question just because of the time. Next question. Okay. Okay. So which of the following reflect the pre-contemplation? It's a long question, but just read it quickly and start answering. So what is the pre-contemplation? We know there is pre-contemplation, contemplation, and so on, maintenance, and so on. Smoking mainly.
Is everybody able to see the poll?
So I'm waiting for the answer. So what is the pre-contemplation? I don't worry about my cholesterol syndrome anymore. It has been, how this are getting this? Pre-contemplation. Yeah, and you have not reached the stage of contemplation, of even putting it in your mind. Okay, okay, excellent. Now it's coming, yes. Okay, the time I think is enough for it, this question.
Dr. Nasir, all the 7 questions are here, so we're going to give them a few more minutes to answer all.
Okay. I don't know when this, if the session finishes in 1 hour or we can.
It finishes at 8:15.
8:15, خلاص, now we have time. Very good. So I want to give each question almost about 2 minutes. Okay, so now, and all the questions, then we rush through them again, or I don't know, you want it one by one?
It's up to you, doctor. Both ways are good.
Okay, I don't know. I think they should finish everything so that then we finish it together.
Okay.
So that we link the thinking and everything. There will be no break when we are discussing the answers. Okay. Let's give them about maybe 9 to 10 minutes, 8 minutes, or 5 minutes, 5 to 6 minutes. Give them the questions.
All right.
Okay. Thank you very much, really.
Doctor, would you like me to end the poll?
Start now, because the remaining 8 minutes, we should make use of it.
Okay.
So, okay, you can start putting the questions. We finished number 1, so we are on the second one, which is the pre-contemplation. Now, many answered this. I don't think I can change my cholesterol and so on, but the answer, unfortunately, from the reference who brought the question, epidemiology, that it is number B. I think I will join fitness club next month, because exercise is going to reduce my risk. So it's actually a functional or cognitive form of thinking about changing behavior. So the answer is B. So next question. We hope in the future we meet and we discuss more. Yalla, next question. So which the next question? Which of the following statements reflect the maintenance stage of the behavior change model? So the answers here I can see, mashallah, the majority I am learning more about low fat substitutions, and I'm trying them with my favorite recipes and so on. Now, okay. Hello? Hello? Is majority almost answered the right answer, which is number D. 43 is D, and that is I make low fat choices when I eat at home. So this is the answer for this question, Ajama. Again, the answer is D. The next question, I think it is the nurse. Yeah. The nurse educator is planning a smoking cessation program. Understand that most basic types of health promotion program is, so what is the answers here? Our answers here. Majority answers, providing counseling for lifestyle, 57. Okay. 43. Yeah, the nurse, this one. I don't know, maybe it's changing the program. So the Jama'ah, I will read again. The nurse educator is planning smoking cessation. This is question number 4. So the answer is A, utilizing a variety of media information and dissemination. I mean media information for dissemination or information dissemination. So the next question, just because of the time, and this is the quick questions. So this is a quick form of questions here now. So is it this one? The public health? Yeah, the public health nurse. Yeah, the public nurse who does, excellent, does blood pressure screening and related health education, is conducting activities of, we know that, all answered 64. This is secondary prevention, because pre-symptomatic detection, anything has to do with hypertension is secondary, is screening. Excellent. Next, the health education who teaches proper body mechanics, bending and lifting, conducting activities of primary prevention. We know. Excellent, excellent, 97%. The clinic nurse who is claims multiple sclerosis, support group providers information about community resources and counseling. And this is tertiary, very clear. Complications. Excellent. The last question. Yeah, a home nurse who provide care and repositioning to a client. We said this is tertiary prevention. Okay. Client on bed rest is conducting, again, a home health nurse who provides skin care. This is tertiary. A repositioning of that elderly maybe person on bed rest is conducting activities. Is it health promotion, health protection, or health prevention, or rehabilitation? The answer is health protection. So this is how many they got it? 14%. But this is the answers from the reference I got. So are you hearing me? People who are still around, they have not gone for prayer.
Yes, yes, we are.
So any question يا جماعة, and I hope really this session is useful. Any comment, Dr. Tazim? Anybody?
Thank you, Dr. Abdulrahman. It's a nice presentation.
Thank you very much.
What will we
your voice, I cannot hear it, Dr. Tazim.
Yes, there is. Now you can hear me?
Can you?
Hello?
Okay. Yeah, can you go ahead?
Overall, it is a very nice presentation.
Wallahi, Dr. Tazim, unfortunately, I cannot hear you. Very far.
So there is some
Why? Maybe my computer.
Okay.
1 minute.
Actually, I can't hear him either, Dr. Abdulrahman.
Yeah, because now I hear you very well.
You are hearing me?
Yeah, now I think it's reasonable. Go ahead, Dr. Tazim.
So it's a nice presentation, Dr. Abdulrahman. You covered from health promotion, primary, secondary, tertiary.
It's not clear.
Sensitivity, specificity, positive.
Dr. Tazim, unfortunately, unless you write it, we cannot hear you at all.
Okay, thank you. So it's we will talk together tomorrow.
Yeah.
It's very nice. Good luck.
Shukran, Doctor. Thank you so much. It was very
really
informative.
All of you for your contribution too. And I'm very happy with an interactive group, and really I hope it will be useful to help us to help our patients in the future, hopefully, inshallah.
Inshallah. Thank you so much, and looking forward to hear from you again in another session. Inshallah. And thanks for our audience all, and thanks for Vicky for arrangement. And see you soon in another Vicky. The last comments from your side.
Abdulrahman. I really enjoyed this session. Thank you, everybody, for coming. This was a very engaging and stimulating session. Thank you.
Nice. Thank you all, and I thank you, Vicky. You really tried with me, have been reminding me, which is very good. Thank you very much for you and for all of you. Thank you very much. Have a nice evening. See you, inshallah.
You too. Thank you so much. مع السلامة. Thank you. نراكم بالخير. يا رب. Thank you.